This test is going to be called the cotton clunk, and it is assessing a syndesmotic high ankle sprain. I'm going to have my stabilizing hand on the distal tib fib, and my movement hand is going to be around the talus and the calcaneus. And what I'm going to go ahead and do is perform a lateral glide. I should be able to feel a 3 to 5 millimeter translation of the talus over the bones, or I could have a reproducible pain that the patient came in for, or there could be a potential clunk or laxity for positive tests. This is the medial subtalar glide test for a high ankle sprain, syndesmotic sprain. So what I'm going to go ahead and do is have my stabilizing hand on the medial aspect of the lower leg. My mobilizing hand is going to be around the talus and that calcaneus, and I'm going to go ahead and perform a lateral glide. And a positive test for this one would be that 3 millimeter translation, or a clunk, or a reproduction of the patient's pain. This is the squeeze test, and this is going to be assessing for a high ankle sprain, syndesmotic sprain. So with this test, I'm just going to go ahead and use my hands over the distal third of the leg, and I'm just going to go ahead and squeeze the two bones together. And a positive test would be a reproduction of ankle pain from the patient. This test is called the Kleiger's test for syndesmotic ankle sprain. So with the patient seated, her leg in this dependent position, I'm going to stabilize the lower leg, and I'm going to go ahead and wrap my hand underneath, gripping on the calcaneus, and I'm going to go ahead and do a passive external rotation force. And a positive test would be a reproduction of the ankle pain from the athlete, or there could be a potential laxity as well. This is the fibular translation test for syndesmotic ankle sprain. So with the patient in a side-lying position, I'm going to go ahead and locate the lateral malleolus, and with the heel of my hand, I'm going to go ahead and get in the right position. So I'm going to go ahead and find the bone itself, and I'm going to go ahead and push out. Another way I could do this is actually put my hands around the bone and I can pull towards me. And a positive test would be excess laxity or a reproduction of the ankle pain. This final test for ankles, high ankle sprains or syndesmotic sprain, is going to be the heel thump test. So I'm going to stabilize the lower leg, and I'm going to go ahead and hit over the calcaneus, and a positive test would be the reproduction of symptoms over the ankle. This next test is called the anterior drawer test, and this is for a lateral ankle sprain, particularly testing the ATF ligament. So with the patient laying down, I will go ahead and stabilize the lower leg, and then all I'm doing is applying, I can stand up, but all I'm doing is I'm applying a forward translation. And positive test would be if there was a clunk feeling or an anterior translation due to excess laxity over that ligament. And just to make sure that you're really on it, you want to make sure that you palpate over that ligament as well. This next test is called the Taylor tilt test, and this is going to be for lateral ankle sprains, and it is particularly testing and isolating out the calcaneofibular ligament. So with the patient in a side-lying position, I'm going to go ahead and put one hand over the calcaneus above it, and then the other hand is going to be over where the talus is. And all I'm doing is I'm applying a downward force over both structures, tilting, and a positive test would be an increase in those symptoms from the patient, and I can also check myself as well just to palpate over that ligament and make sure that in fact it is that structure. You would also feel some laxity as well for a positive test. A test that you can do to test for the vascular is Homensign, and you want to do this if you have fear of a potential DVT. So what you're going to do for the patient is you're just going to squeeze the calf, and you're assessing for any positive signs or any positive reproduction of pain. To make this a little bit more sensitive, you could also dorsiflex the foot and then squeeze as well. You would also want to do this with some other circulatory assessments, maybe like a possible Wells scoring system or potential pulse, just to increase the sensitivity of this potentially being DVT related. This next test for vascular is going to be called the Berger's test, and with this test the patient's going to be supine. I'm going to elevate the leg to 45 degrees and we will be holding for about 3 minutes. And during this time, I'm going to be assessing for any color changes, any changes within the actual superficial veins themselves. And like I said, we're going to be holding here for about 3 minutes. Then during that time, we'll move them to a dependent position. And what I'll be assessing for is how quickly that the color changes back to normal. It is abnormal if it takes longer than 1 minute for the blood supply to be back to the foot. Again, the sensitivity for this is pretty poor, so you want to go ahead and do this together with some pulse testing as well, just for further examination for circulatory. These next tests are going to be assessing for Achilles rupture or potential Achilles strain. And the first one I'm going to go ahead and explain is the Thompson test. For this exam, what I will have the patient be is in a prone position, and just by me doing a grip over the calcaneus, by me gripping over the gastroc, I should see some plantar flexion. And for somebody who had a significant rupture, you wouldn't see that. So another test that you can do that has a little bit more sensitivity for those strains would be the Maddles test. And with that test, I would just ask Alex to slowly bend her knee actively. And I'm looking at the foot positioning the whole time. And you see that this is in a plantar flex position, so this would be a negative test. If it was positive, you would actually see this foot go into dorsiflexion as she is going. And you would see like a little bit of laxity and fall with that. And that would show that there was an actual injury to that Achilles itself. So this next test is called the Royal London Hospital test, and this is actually going to be assessing more for Achilles tendinitis or tendinosis issue. So what I'm going to be doing is, with the patient prone, I'm going to pinch the Achilles itself just to kind of assess how it feels. The patient might even express some pain with that. So with that, I'm either dorsiflex the ankle while pinching it, and the patient would then describe for this to be a positive test of reduction in pain. Actually, would I do that? So again, this is more so for those chronic conditions for the ankle. And a negative test would be if there was no change at all. Maybe she still has the pain and it didn't feel better when I did that passive dorsiflexion. These next tests are for potential neurological conditions. This test I'm going to be doing first is called the Tinel's test, and there are a couple different locations where we want to do them. I'm only going to be showing you 2 out of the 3. So the third one I'll explain to you is for Morton's neuroma, and you would actually be passively extending the toes, and then you would be tapping over between the second and the third toe. Where I'm going to show you right now would be for next to the posterior tib. And I would go ahead and go to the medial malleolus, and I would be tapping right directly over that area. And a positive test would be any tingling or numbness distal to that. Another good area that you can do is going to be the anterior tib. And for that nerve, I want to go ahead and tap over where the insertion is for that tibialis anterior muscle. So I'm going to go ahead and tap over there, and that nerve is sitting right in that same area. So a positive test for that one also would be some tingling and numbness in the distal extremities. This next test is called the Morton's test, and I will be going to be doing this if the patient is complaining of tingling and numbness in the foot, specifically over the metatarsal heads. So what I'm going to go ahead and do is squeeze over that area. And a positive test would be if the patient has an increase in symptoms. Specifically, it would be more so right in between that second and that third, just because that's usually where you have that nerve sensitivity due to that Norton's neuroma in that area. Okay, so this is the Feast line test. I'm going to go ahead and make my markings where I need to have them. So I'm going to have it on the inferior, the medial malleolus. And then I'm going to go ahead and find the navicular and the first MTP as well.
Okay, now it's on. Ready? Still playing the part? Oh, no way. What did you do to my thing? Isn't it weird? I don't like this song.
Okay, we will behind my
Isn't that like this like uncomfortably
Good.
bad?
And then I'll have the patient stand
No,
up.
it's just, like, oh, it is like clay on that side.
Good.
Steven, what did you do?
And then with the line, I'm just kind of assessing where the navicular would be to. The navicular tubercle normally lies on or close to the line joining the 2 points. If the tubercle falls 1/3 of the distance to the floor, it represents a 1st-degree flat foot. If it falls 2/3 of the distance, it represents a 2nd-degree flat foot. If it rests on the floor completely, it represents a 3rd-degree flat foot. This next test is the functional hallux limitus test. So to begin, the first thing that I want to go ahead and do is put the actual patient in subtalar neutral. Okay, so, yeah. All right, so now from here, what I would go ahead and do is give a passive force into first metatarsal dorsiflexion or extension. And what I'm doing is I'm assessing to see if there is any plantar flexion of the MTV itself. And this would be good just for assessment of the actual positioning of that first MTP and to see if there was any abnormalities within that. This test is called the windlass test, and with the patient standing on the table, I'm going to go ahead and assess her mobility of the first ray. So I'm going to go ahead and extend that toe. Good. Normally, this action will cause elevation of the medial longitudinal arch and lateral rotation of the tibia. If both actions do not occur, the foot cannot function normally. Pain or increased pain at the insertion of the plantar fascia indicates positive test for plantar fasciitis. Lack of extension may indicate hallux rigidus.